Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, conventional wisdom says that it takes 5 to 7 tries before you can actually quit smoking, before you can really give it up. But there's a new study out in the journal BMJ Open that says those estimates may be too low.
Wow, researchers compiled data on more than 1,200 adult smokers in Canada and found that the real average number of quit attempts before succeeding might be closer to 30.
Amazing. Well, we know that nicotine is highly addictive, and trying to quit smoking, especially without help, can be really difficult.
Go ahead.
Here to offer some strategies to stop smoking is internal medicine specialist at the Mayo Clinic Nicotine Dependence Center, Dr. Jon Ebbert. Welcome to the program, Dr. Ebbert. Good to see you.
Pleasure to be here.
So this drug, this chemical nicotine, is truly addicting, isn't it?
It truly is. There's about 1 in 5 people in this country that still smoke.
20%.
That's about, just under 20%.
But that's down from what?
So when you looked at the 1950s, about 50% of the U.S. population was smoking.
So what is it that's so great about nicotine? Why is it so addictive?
So nicotine releases dopamine in the brain, and dopamine release is very reinforcing. And then there's a lot of social and contextual factors. It helps people cope with stress. People love to smoke.
If back in the 50s, 50% of the people were smoking, that's fine. They didn't know any better. But these days, for 1 in 5, is that what you said, 1 in 5?
Yeah, 20% of the population.
To still be smoking, are they still smoking because they just don't care or because they can't quit?
Great question. In fact, if you look at some of the more recent data, what you'll find is that about 50% of the current smokers aren't smoking every day. So the point is that if in the 1950s most of the smokers were smoking every day, we're seeing something different today. And the smokers are unique. So about 50% of the current smokers don't smoke every day. And of the ones that do smoke every day, about 50% of them smoke less than a half a pack.
No kidding.
Yep.
Well, how do you not smoke every day? I mean, I would love to just smoke on Friday nights and have one smoke in the morning. I mean, how do people do that?
Many people do.
Really?
And that's what we're seeing. And so it actually does impact the way that we communicate risk to these patients. And they may say, well, I only have 1 or 2 when I'm having an alcoholic beverage on a Friday night, and then I don't need to smoke the rest of the week. And it also creates problems, at least behaviorally, because it's real intermittently reinforcing. And so it's almost a harder habit to extinguish sometimes.
So it doesn't take very long to get addicted to nicotine. I remember when Richard Hurt used to come on the program. I mean, it's a pack of cigarettes or a half a pack or 10 cigarettes or something. It doesn't take very long to get addicted, does it?
It does not. And what's interesting is if you took twins and you gave them a cigarette, and they both smoked the cigarette, one may have a very different response. And a lot of the differences in response between individuals are what we believe truly sets them up for a lifelong addiction.
Does it make a difference if you try cigarettes when you're a teenager versus if you were to, I'll try when I'm 29 or something? Does that make a difference?
Well, it's interesting because if you look at all addiction, not just tobacco, if you can keep someone off an addictive drug until the age of 25, the likelihood they'll be a lifelong user of it is almost 0%.
Oh my.
99% of all addiction starts well before the age of 25. And for smoking, it's 99% starts before the age of 21. And we talk about some of the cases later. A lot of the stories I hear, the smokers that come in, they started smoking when they were 11, 12, 13, 14.
Out behind the barn.
Yeah, that's how addiction starts.
We're not talking about your story here. But since you brought it up, do you think that you could be one of those people that just once a month would have a cigarette with a drink?
No, don't
you
think
would
so.
go back.
Yeah, it's like an alcoholic or somebody who's previously smoked said, I'll just have one.
Yeah,
no
don't think it would work for you.
Nuh-uh. I'd be back to a pack a day.
And that's
no
fascinating because that's what I hear. So when I'm sitting where I'm sitting in a specialist clinic treating tobacco addiction, the story will invariably be exactly what you said. We will hear someone said, I was doing so well for so many years, and I thought I could just have one. Mm-hmm. It's true of every person struggling with addiction. I've never heard someone struggling with addiction who didn't say, I wish I could just control the behavior. That defines addiction.
Interesting. So there are some people who are still taking up smoking. And who are those people? It seems like I read not so long ago that it was high school girls. Is that still true, or am I
So
wrong?
yeah, so we certainly see, and once again, all this initiation is happening well before the age of 21 most of the time, but we're seeing a changing demographic. So these may be non-daily smokers, but these are the smokers out there. So we're seeing a lot of non-daily smokers.
I just have to ask at the very beginning when we were saying that Canadian study, do you think, is that sound right, that the number of times a person has to try to quit is 30 times? Is that closer to the truth?
Isn't it Mark Twain says quitting is easy? I've done it 1,000 times, so
Right.
maybe it's much higher than 30. And actually, they gave a range that went well beyond 30. That makes sense to me.
It does.
It makes sense to me because when you think about addiction, we treat it like a chronic disease. And chronic disease is characterized by relapse and remission. So they quit and then they go back. They quit and they go back.
But I would think that if I was someone who was battling a nicotine addiction, that the average is about 30. I'm trying to think if that would be good news for me or bad news for me. Good news, like, oh my gosh, good. It takes that long for me to get the hang of this, or, oh my gosh, I'm never going to get the hang of this.
What's interesting is if you dig into the data a little bit more, what you find is that most quitting attempts happen at the spur of the moment, or a significant percentage of these, quit attempts happen at the spur of the moment. So there was a study that they looked at people who quit, and it wasn't about planned, behavior. It wasn't about let's get you on the patch and pick a quit date. It was about I'm quitting right now because I just had a heart attack. So that's how most of quitting happens. So maybe not 30 times planned quits. Maybe some of these are spontaneous or spur of the moment.
So we're going to talk about more about the Nicotine Dependence Center coming up, but briefly review for us, what are your favorite stop smoking aids?
So nicotine replacement is a really foundational sort of cornerstone of therapy. So we like to think about nicotine replacement as building a bridge to a tobacco-free lifestyle. So I have a lot of patients who come in and say, and they've been smoking for 34 years, nicotine's the problem. I think we in public health have done a horrible deed by saying nicotine's the demon and saying, hey, by the way, nicotine's a demon, but I'm going to put you on 4 patches, give you a nasal spray and inhaler. That's a really bad and confusing message. The message is tobacco is what's going to kill you. 2/3 of all tobacco users will die of a tobacco-related illness. And so that's powerful motivation to quit. Nicotine's not the demon. Nicotine is an aid to quitting. And if I, as a practitioner, because I've seen so many patients die from this addiction, if they're on nicotine for the rest of their life, I would consider myself successful because I just want them off the tobacco.
So instead of saying nicotine is the demon, you could say nicotine is the answer.
It is. It is the answer. And right, which is also a little bit confusing message because
Well,
they
let's
are
just start
smoking.
it.
Yeah, well, let's start it here right now. Nicotine is salvation for many of these patients because it is effective. So we have nicotine. We have bupropion, which is Zyban, or generics. So bupropion is an antidepressant that really helps with craving. Then we have varenicline. Varenicline is a new molecule that acts very specifically on the nicotine receptors. And so those are our 3 main foundational drugs.
All right, Dr. Jon Ebbert, he's an expert on quitting smoking and an internal medicine specialist at the Mayo Clinic. We need to take a short break, but when we come back, we're going to be talking about the Mayo Nicotine Dependence Center and what programs you have available to help people quit, and we're going to do a myth or matter of fact.
Yeah, if I'm a longtime smoker, it's too late to quit because the damage is already done. We're going to find out.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are with Dr. Jon Ebbert. He's an expert on quitting smoking, and he works in the Mayo Nicotine Dependence Center. And we'll start this segment with a myth or matter of fact.
All right, Dr. Ebbert, if I'm a longtime smoker, it's too late to quit because the damage is already done. Is that a myth or a fact?
So that's a myth. It's never too late to quit. And we see, even in patients who've been smoking for 40, 50 years, when they quit smoking, we see 50% risk reduction in cardiovascular events within the first couple of days. Patients who quit smoking go back to the baseline rate of lung cancer within 15 years. So it's never too late to quit. What I will hear from a lot of patients is they say, my cough is getting worse.
When they quit.
When they quit.
Yeah.
And so what's happening is when you smoke, you put the cilia in your lungs to sleep, and those move move the mucus out.
Yeah, they're the little hairs on
They're
the
the little
lining
hairs.
of the breathing tube. Yeah.
That's exactly right. And then you put them to sleep with the cigarettes, and then when you quit, they wake up and start mobilizing that mucus, and so that increased cough as you're starting to clear that the particulate matter that you inhaled with every cigarette can take several weeks or months to clear.
But it does go away.
It does go away.
Yeah,
Yeah.
but it's such a good thing. Yeah, and you get everything clears out. It's just it's wonderful. But you'd still like a cigarette with your coffee the next day.
How long did it take you? Let's just
To
say,
what?
To how long
For
did you
mycelia to start working
No,
again?
how long did you smoke, and how long did it take you to quit?
Oh, I probably smoked for 20 years. But everybody, a lot of people in my high school smoked,
Right.
and I think we knew better. But the first Surgeon General's report that came out and said that it caused lung cancer didn't say anything about stroke or heart disease. Was 1960. So in 1960, we sort of knew that it was good. And, when you would run up a flight of stairs and you couldn't breathe very well and you would get short of breath, you knew it wasn't good for you. But
Yeah.
everybody was doing it.
Right.
All right, so I got to ask you about when we were talking about stop smoking age. The thing that you mentioned was that nicotine is the culprit, but it's also potentially the answer. So what about vaping and e-cigarettes? Do they have nicotine in them? Don't they?
So they do have nicotine, and they are probably 96% safer than conventional cigarettes.
Because the tobacco isn't present.
Because the tobacco you don't have any burned tobacco products that you're inhaling. The health concern that we have is that there are flavoring agents in there. And some of these flavoring agents have been shown to potentially increase the risk for cancer. We don't have long enough data to prove that they increase cancer, but at least in studies that they do in the lab, it could increase the risk for cancer.
So you don't know for sure what's in an e-cigarette. There's no regulation, right?
Right. It's currently not regulated.
Okay, so first of all, you wouldn't recommend an e-cigarette for someone who never smoked. And second of all, you would not recommend vaping or e-cigarettes as a method to help people quit.
So it's a complicated issue. We sometimes confuse the two messages. There's one message of whether or not I, as a physician, recommend it to my individual patient versus whether or not I recommend that people should have access to it. One's a public health question. The other one's an individual counseling with my patient question. So I may be someone who says I think people should have access to them at a public health level, meaning I don't want to make them illegal, don't take them away, but I would never recommend it to my individual patient, because if I recommended that as treatment to my patient in 15 years, they get lung cancer from the e-cigarette, that might be on me. Not saying it is, because it's hard to figure out whether it was the smoking that caused it or the e-cigarette. But I don't want to create more problems for my patients. All the things that I recommend I know are safe and are FDA regulated. There's no regulation here, so I don't know what's in it truly.
All right. Well, we want to talk about the Nicotine Dependence Center and the programs that you have available. Tell us about an interesting patient that you've seen recently and treated.
Okay, so one of the most exciting experiences I have is with the residential treatment program that we have. And we actually have these patients come in on a Friday, and they're with us for an entire week. And they leave the next Friday. And so what we see is people that have really been down that road of trying to quit multiple times. They've tried to quit
30 plus.
30 plus, yeah, agreed. And now they're in there. And, I see so many patients there, that I can really see what kind of grip and what kind of hold tobacco really has, having not been, I was a chewer, actually. I was not a cigarette smoker, so I never really understood the hold that cigarette smoking had on people until I started doing that program, and then I really began to appreciate it. But what's so gratifying for me is when they get done and, you'll see them months later, they've quit, and they say, you saved my life, and you saved my life. And what's amazing to me, and it's hard for me to communicate this to someone who's still currently smoking, is Tom may, kind of reflect on this, but nobody ever regrets quitting smoking. They never say, boy, I wish I was still smoking. And so what's gratifying to me is they do have that perception that we've saved their life. They do have that monkey off their back, as I like to say. But also it provides them an opportunity to say, I can live without cigarettes. Because I think when patients are trying to quit, their biggest struggle is, what am I going to do instead? How am I going to cope with my stress? Am I always going to feel this crummy? as I do when I'm quitting? And the answer is no, but it takes time to feel better and get back to that baseline. So, so I think the people that I see in the residential are the people that most affect me deeply and most make me passionate about this field, because you do see such a miraculous transformation. These people have been struggling with addiction for years.
Now, so what's your success rate in the residential program?
So about 6 to 12 months, we're 50%.
All right.
So that's some of the highest rates you see in the country. There's 2 other programs in the United States that do this type of treatment. Those are very high quit rates. The nice thing about tobacco treatment is that we see a dose-response effect. That is, the more intense the treatment, the better the patients do. And you can't really get more intense than having someone sort of be in a residential setting for 8 days. So that's the kind of treatment rates we see.
All right. So if somebody didn't want to do the whole week program, what other programs do you have, and tell us their success rate?
So so we're about 25 to 30% in our outpatient clinics quit rates, and so we have an outpatient clinic. You can call in, and you can visit with a counselor, have some face-to-face one-on counseling. Those counseling sessions are supervised by me and my other colleagues, and we will write the medication prescriptions. And so we have that opportunity as an outpatient if people want to come in.
And I presume you have people who call you, they try to quit, they haven't been able to, and they come back and they try again?
Right. We see a lot of people. We see a lot of people coming back into the residential treatment program. We've seen people 2, 3, 4 times in the residential treatment program. We certainly see that in the outpatient as well.
Now, you've got all these modalities to help people smoke, the different kinds of nicotine replacement. How do you choose, or is it kind of up to the patient? You say, here are your options for nicotine replacement. You choose which one you want?
What I like to do is I like to talk to the patient and say, what have you tried before? That really helps me direct my therapy, because we certainly have a lot of medications we can choose from, and we use them all in combination. If I could get patients to use every one of them and they feel like they could afford it, I would give them all, because all of them work a little bit differently. I like them in combination. And so what I usually start with the question is, what have you tried before? What have you found that might be effective? And then I get an understanding of how many times they've tried to quit before, and then I might make a decision about whether I combine the patch with the gum, or just the gum alone, or just the patch alone.
I would have to imagine if someone is a smoker because they can't handle stress. I mean, that is a huge thing that you have to address on top of dealing with this addiction.
So important. I agree. Thank you for mentioning that. So and I talk about the pharmacotherapy a lot, but so important is the behavioral treatment that goes along with that, because it's the behavioral treatment combined with the pharmacotherapy that give us the best outcomes.
You know, one of the most interesting things I think I heard you say today was that if you can get someone off tobacco, even if they're on nicotine for the rest of their life, in some form, you feel like you've been a success.
Absolutely. I've seen way too many people die from this addiction.
Wow, Dr. Jon Ebbert, he's an internal medicine specialist, and he also is director of the Mayo Nicotine Dependence Center?
I'm an associate director.
Co-director.
Yeah, it's
associate.
co-director.
All right, great to have you with us.
Thanks.
Great information.
Okay, thank you.
Still to come on Mayo Clinic Radio, we'll learn how cochlear implants can help with hearing loss. And later on in the program, an update on laparoscopic pancreatic surgery.